Good afternoon, ladies and gentlemen. You're welcome to today's webinar on another important subject in our setting. I am Dr. Kasirye Phillip. I'm a pediatrician at Mulago National Referral Hospital, where I also oversee the activities at the Sickle Cell Clinic. Today, we are privileged to have Dr. Rebecca Nantanda. Dr. Nantanda is a renowned researcher and a pediatrician. She works with the Makerere Lung Institute. And so she's going to take us through the respiratory complications in sickle cell anemia. So by way of introducing the subject, I just wish to refer you to the slides that are being broadcasted across. That sickle cell is a genetic disease in which the blood cell become sickle-shaped under certain conditions, and especially low oxygen tension and or dehydration. It's autosomal recessive in terms of inheritance, and the disease manifests phenotypically in homozygous state. So the underlying pathophysiology is that normally we have the hemoglobin A, but when you have a gene for sickle cell in heterozygous state, in other words, eukarya, there is a chance of actually transmitting this gene to the offspring. And especially if two carriers need to have babies, there are chances of 1 in 4 of the baby, of 1 in 4 chances of that pregnancy having a homozygous state or 2 genes, 1 from each of the parents. So the abnormal sickle cell, which is called a sickle cell hemoglobin, sickle hemoglobin, results from a single switch mutation with replacement of glutamic acid by valine in position 6 of the beta globin chain, and under conditions mentioned up earlier, that is low oxygen tension and dehydration, amongst others. It undergoes polymerization, resulting into distortion of the normal discoid cell of the red blood cell into the sickle cell or sickle type of cell. This renders the sickled cells very sticky and rigid, and as they go through the narrow corners of the small vasculature, they actually adhere to the walls, vascular walls, and adhere to each other, and thereby cause blockage in these small vasculatures. And as a result, we have ischemic effects, distal to the point of vasocclusion, which may manifest as pain initially, but later on we may get results of end organ damage or failure. So looking at the epidemiology, it is estimated that 5% of the global population carries the sickle cell gene and thalassemia gene. These are the common hemoglobin disorders. And about 300,000 babies are born with this abnormal sickle cell gene in Africa each year, no, globally, and 75% of these are in sub-Saharan Africa. So as far as Uganda is concerned, earlier estimates have put figures around 20 to 25%, 25,000 newborn babies born each year with sickle cell disease, and 50 to 80% of these die before the 5th birthday. Of course, the statistics, the figures are improving with improved care and nutrition, but these are the earlier stated figures. As a result, it has drawn the attention of the Ministry of Health that has actually set up several interventions starting with formation of a sickle cell desk within the non-communicable diseases department. And over the years, it has carried out several activities. Some of the early activities included starting up of a newborn screening program in 2015, which has been rolled out to several facilities across the country, starting with the regional referral hospitals, and then also creating awareness as well as coordinating the other stakeholders, that's a non-government organizations that have come in handy in as far as creating awareness amongst the population. The recent or the most remarkable was the 2017-2019 Kabaka Birthday Run, whose main theme was focused on increasing awareness of sickle cell. There's still work in progress, and we still have a lot of work to do together. But around the same time in 2015, the ministry carried out a national sickle cell surveillance that by and large mapped the disease across the country and showed that we have sickle cell across the country, but with a higher prevalence in the mid-north, the areas that are shaded in magenta shade or purple shade or pink shade, followed by the east and central. We have a mid-north, actually sub-region. We have the east central, stretching from around Jinja to Soroti area, the central, followed closely by the central, and lastly, in Western Uganda, where we have the least prevalence. So national prevalence stood at about, of the traits stood at about 13.3%, and that of the disease stood at about 0.7%. Of course, these were based on a HIV screening program, the early infant screening program, but by and large, they gave an indicator of the national distribution of the disease burden. So having said that, and without wasting more time, I wish to welcome you to listen to Dr. Rebecca Nantanda, who is going to take us through some of the complications that our patients experience. And specifically, she's going to delve into the respiratory complications of sickle cell disease. Thank you so much. Over to you, Rebecca.
Thank you, Dr. Kasirye. If you would kindly unshare so I can share my slides. Can somebody confirm that you can hear me, please?
Yes, we can hear you loud and clear, Rebecca.
If you could kindly unshare your slides so that I can start sharing mine. Thank you so much. So good afternoon, everyone. I'd like to confirm if my presentation is in slideshow mode.
That's correct.
Okay, thank you so much. Once again, I'm privileged to make this presentation. My name's Rebecca Nantanda. I'm a pediatrician, and I also work with the University Lung Institute as a research scientist. And I'm going to share some insights on the pulmonary complications of children with sickle cell disease, specifically focusing on how this impacts on their lung function. But before I start the presentation, I think I wish to really extend my thanks to individuals, organizations, and institutions that are at the forefront of really improving the lives of children with sickle cell disease. I think it has been a long journey. There is still a lot of work to do, but I know there are many people into this space, and I salute you all. So why this presentation, or why this topic? I think the reason I would like to share this information, number one, is to increase awareness about the lung health problems among children with sickle cell disease. Not to say that people are not aware, but I think there are some aspects which we can focus on a little more to improve their lives. But also secondly, I would wish to highlight what are the possible practice gaps we currently experience and how could they be contributing to the avoidable deaths in these children? Are there any potential benefits given the current therapeutic interventions that we have? And lastly, being from the research perspective, I still think there is a lot of research that we can do to improve the clinical care, to address policy issues, as well as training gaps. So I'll touch first on lung growth, development, and the function. Then I'll move on to discussing sickle cell disease and how this impacts on lung function, on how the lung function of these children is impacted. And then I'll go on to discuss some lung complications in children with sickle cell disease. And finally, I'll deal with the interventions that I've been able to find. In this presentation, I might use sickle cell disease broadly, but largely the information that I'm going to share actually focuses on sickle cell anemia. So before I discuss sickle cell disease, let's just have some discussion about how the lung grows, how it develops, and how eventually the function comes around. So number one to note is that lung growth and development starts when the baby is still in the womb, and that's very important because as we shall see later, what happens to this baby during that period when they're in their mother's womb contributes greatly on how their lung function will be, and therefore the eventual risk of lung diseases. The lung growth starts in utero, it continues through adolescence, and then it ends by early adulthood. And then after that, our lung function actually starts declining. So I can confidently say that if anyone is on this call and is aged 22 years and above, your lung function has already started declining. And the intrauterine period is really very important, as well as the infancy period. And we usually say the first 1,000 days actually very critical when you look at lung function and development, because it is characterized by rapid lung growth. And therefore, if anything happens to the baby's lungs, any insult, whether from the mother, whether from the outside world, it greatly impacts on the lung capacity and function. And there is a lot of research that shows that once the baby is born with suboptimal lung function, this actually increases their risk of disease later in childhood as well as adulthood. So the things that happen in the first 1,000 days of life have a life course risk of developing lung problems. Some of the factors that we know that influence lung growth and development, and these have been extensively researched. We know, like I mentioned, the prenatal period is very important. So maternal health as regards to maternal nutrition during pregnancy, air pollution exposures, tobacco smoke, either use or exposure, and diseases which I'll not mention, but in general, the maternal health is very important because it determines how the organs of the baby actually grow and develop and how they will function after birth. Now, when the baby is born, we have the extrauterine environment. It still affects the lung function. Like I mentioned, that lung growth goes on until we are 22 years of age. So nutrition, air pollution exposures, diseases, especially respiratory infections, as well as genetics, play a big role in determining how your lung function plays out as you grow older. So I'm going to use these terms around lung function. So I just thought I would mention them up front. So one of the tests that we do when we are talking about lung function is spirometry. And it's a simple test, which basically is about measuring the breath. It is simple, it is non-invasive, it's becoming more relatively available. But in this test, the best principle is that we tell the patient to forcefully exhale. So we call it a forced maneuver. There are some instructions we go through. So if you figure out the lungs where we are telling the person to take in a deep breath, and then we tell them to forcefully exhale or to forcefully breathe out, then we measure the amount of air in terms of volume they're able to forcefully exhale. And we also measure the rate at which they do that. So the indices that I'm going to describe are the common indices that we look at when we are talking about lung function. And so when we are telling that patient to take in a deep breath and then eventually forcefully breathe out, we measure the amount of air that person is able to breathe out in the first second. And we refer to this as the forced expiratory volume in the first second. It's very important because we use it to determine if the lung function is okay or not. Now, the total amount of air that that person is able to exhale, usually 3 seconds for children, and for adults may take up to 6 seconds. That is what we call the forced vital capacity. And then lastly, we determine the ratio of the amount of air you're able to breathe out in the first second over the total amount of air you're able to breathe out. And we refer to that as the FEV1 FVC ratio. These are the common parameters, and they have been extensively used in research, and they're the ones which we use to determine if an individual's lung function is normal or is not normal. And so when we receive these results, we interpret them in 2 ways. So for every individual, the amount of air you're able to exhale depends on your age, on your height, on your weight, your ethnicity, as well as your gender. So we look back at what you've been able to exhale and compare it to what we expect given those parameters. And then we are able to tell whether it is normal or not. It's something similar we do when we are looking at nutrition in children. So that is about spirometry. And it's very important when we are looking at pulmonary complications in children with sickle cell disease. Another important test, which is not readily available, but it's very important when we are looking at children with sickle cell disease, is what we call diffusion capacity. And basically, this is looking at how the membrane between the alveoli and the capillary, how the gaseous exchange occurs. Because we know that after breathing in the air, it's supposed to cross that barrier and end up into the vessels to eventually take the oxygen to the different parts of the body. So we also do that test to determine how well your lungs are functioning. There are many other lung function tests, but for the purpose of this discussion, I'll just focus on spirometry. And as I present some of the research information, I hope we shall be able to move along together. So when we do the spirometry, 3 possible results. Either we determine that you have normal lung function, or you have an obstructive defect, meaning that when you're breathing out air, it shows that there is some form of obstruction. Or it could be restrictive, meaning that your lungs are not expanding appropriately for some reason, and then the amount of air you breathe out shows us that there is some restriction as you try to breathe out. Sometimes it is mixed type, meaning there is both obstruction and restrictive, but occasionally we are not able to tell whether it's any of the 4 above, and so we refer to this as non-specific. So I'll use these terms as we go along when I'm discussing lung function in children with sickle cell disease. So I earlier mentioned that lung growth starts in utero, and that by the time we are 22 years, we have reached the peak, and then we start having decline. So this graph shows different trajectories. What we know that if you are born and your lung health is suboptimal, it tends to remain suboptimal until you reach the peak. So I'll start with the red one. If you look at the red curve, these people who have what we call supernormal lung function, by the time they are born, their lung function is supernormal. It follows this trend through childhood to puberty. Around 22 years, we reach the peak, and then it starts declining. The green line is where we have majority of us lie. So again, we follow the same trend. And then by about 22 years or slightly after, we start declining. Now, for some people, if they're exposed to some of the issues that I mentioned earlier, like air pollution, if they're malnourished or whatever it is, they will follow that blue curve. They will have a downward trend, which is declining very fast. So that's why it is very important that exposure to those influences is prevented early on so that you don't have a quick decline in your lung function. Then for the people who start with suboptimal lung function, they reach the peak, but also can remain normal, or they can have fast decline. Later on, we shall discuss how this applies to children with sickle cell disease. But what we know is that the children with sickle cell disease are likely to start off at a lower level, and then also may have faster decline if nothing is done to prevent the faster decline. Now I'll move on to sickle cell disease and lung function. So we know that sickle cell disease affects many organs, the heart, the brain, the limbs, whatever it is. I think it can affect all body organs. But one of the main organs that is actually affected is the lungs. And when you look at the lungs, it affects the different parts of the lungs. So the lungs have different spaces. It has the bronchial tree, that is the airways where we breathe in air and then we exhale the carbon dioxide. We have the lung tissue, which we refer to as the parenchyma. And then we have the vessels that help us to transport oxygen to the different parts of the body, but also bring back carbon dioxide. So for a child with sickle cell disease, unlike maybe other conditions, all those different parts of the lung can be affected by sickle cell disease. And when you look at the lung function, it is determined by mainly the repeated vaso-occlusive events. And it is because they lead to ischemia, there is inflammation, there can be vesicular proliferation, there is endothelial dysfunction, as well as oxidative stress. So as Dr. Kasirye indicated earlier, the pathophysiology of lung of sickle cell disease, these events, they can happen anywhere, but they also happen in the lungs. And that's how they eventually affect the functioning of the lungs in these children. So this is just a diagram to illustrate what I've just discussed. So if you look at those several balloons, they represent the alveoli. And we have the blood vessels, both the veins, the capillaries, and then the arterial end. So on the right is where we have the air moving in and out. So from the airways, the air finds itself into the alveoli. And then we have oxygen crossing that membrane into the blood vessels where we have the red blood cells. And then we have carbon dioxide coming from the veins back into the lungs, and then we breathe it out. So what happens in this inlet and outlet where the air passes? What happens on this surface or in this membrane between the alveoli and the capillary, and also within the capillary? When all these get combined together, they influence the lung function of children with sickle cell disease. And as I will discuss later, children with sickle cell disease can have problems within the airways. That means the pathway where the air comes in and out. They can have challenges with this membrane where we have the exchange of oxygen and carbon dioxide. But they can also have challenges within the vessels where we find the red blood cells that are eventually supposed to take the oxygen. And that really determines eventually how their lungs function. So we know that many children have suboptimal lung function. I'm talking about children with sickle cell disease. Sometimes they have the symptoms, but sometimes they don't have the symptoms. So not having symptoms does not mean that your lungs are automatically functioning properly. And we'll discuss the importance of this at a time. But it's also clear that abnormalities in the pulmonary function in these children is usually the first sign to show that there is a problem with their lungs. And so it's really very important that we detect these lung function problems very early, probably through screening. And we know that when we do this, we can intervene early and we are able to reduce the mortality that is associated with these pulmonary complications. So I'll just share some information, some research. First to mention that there has been quite a lot of research in this space of sickle cell disease and lung function. But unfortunately, most of this research is in North America, is in Europe, a bit of South America. We still have little research in sub-Saharan Africa. And I want to believe that the biggest people who are affected by this disease is in sub-Saharan Africa. So I think we have room to do much more to see how we can improve the understanding of sickle cell disease and lung function in our setting. So in Uganda, I'll start with a study that was done right there in the sickle cell clinic of Mulago Hospital by one of the M-Med students. She's now a pediatrician. So she looked at children 6 to 17 years. There were 332 children. This is one of the biggest studies we actually have in Africa. And 37.9% of them had abnormal lung function. Like I mentioned earlier, we can classify the abnormalities as obstructive. So in this case, 45.2% had obstructive defects and 53.2 had restriction, while 1.6 had mixed. There was no one with non-specific findings. In Nigeria, there was another study, again done in children 6 years and above, and it's because these are the children who can perform spirometry. But this also included some adults, but at least half of them, more than half of them were children. Again, obstruction was 28.3%, restriction 67%, and mixed type 2.2%. The study in Malawi, a very small study, just included 25 children. They didn't go ahead to classify the restriction, but they noted that at least 62% of them had abnormal lung function. And then another study in the PRC, this was a case control. So they looked at children who had sickle cell disease and matched them with the controls. And they found out that abnormal lung function in the obstructive category, 4.5% had, while the control had 1.9, 26.8 in the restrictive control, or just 1%, and then the mixed type 6.2, while the control had 0. So the bottom line from this slide is that it seems like in Africa, majority of the children with sickle cell disease and have abnormal lung function, they have the restrictive type, but we also have a significant proportion with obstructive type. This is another study which was done again in Nigeria in a teaching hospital. It was also a case control study. So this figure just illustrates the differences in the volumes between the controls, meaning those children who did not have sickle cell disease, and the cases, those who had sickle cell disease. So we find that if you look at the forced vital capacity, the FVC, as well as the FEV, there was a stark difference. So the T is the test, that means the cases, and then the red one or the maroon one, that's the control. So there was a difference in the lung volumes, with the controls having better lung volumes compared to the cases that are in blue. When it came to the ratio, that was similar. And this is usually because it's a mathematical
Rebecca, your audio is off and you have lost your network.
My apologies. I had some challenges with the internet. I hope, can somebody confirm if they can hear me now?
Yes, Rebecca, you are back.
I want to believe, okay, I want to believe that this is where I got disconnected, so I can start from here. So I was just saying that this is a study, a control study in Nigeria, where they compare children with sickle cell disease and those who did not have sickle cell disease. And it clearly showed that children who had sickle cell disease had lower lung volumes compared to the normal children. And this was the case for the FVC, the FEV, but the ratio was similar just because it's really a mathematical thing. But the bottom line is that children with sickle cell disease, even when they're of the same age and gender and from the same environment, usually have lower lung function. So talking about more about this lung function and sickle cell disease, obstructive defects seem to be more common in high-income countries. And like I mentioned earlier, restrictive defects in low and middle-income countries. We don't know why, but I think it's subject to research and therefore informed interventions. We seem to find that older children tend to have more of restrictive defects as opposed to the younger children. But what is important is that when you look at the obstruction, meaning that the airways are a little narrower than they should be, many times we think that this is because of asthma, but when it comes to children with sickle cell disease, we find that there is a type which is not really at all related to asthma. And this is very important in clinical care because the finding of obstruction on does not necessarily mean that the child may have asthma, and therefore you have to look for other potential causes. And so in one study, it was found out that those who had irreversible obstruction, meaning that when they gave them a bronchodilator like salbutamol, they did not respond, were actually almost half at 47%. So this group would not be treated for asthma, yet they still have an obstruction. So in this group, they think that the mechanism may be because there is compression of the small airways by the congested peripheral pulmonary vessels. We are yet to clarify that in our setting. But this was deduced from the fact that there was a correlation between the pulmonary capillary volume as well as the airflow limitation. So this is a subject for further research to know how we can actually manage these children. Now, what kind of children end up with abnormal lung function? Again, this is from studies that have been done. And we know that if a child has sickle cell disease and is wasted, they are more likely to have suboptimal or abnormal lung function. The female gender, increasing age. So if you look at children with sickle cell disease, if you measured their lung function, let's say at 3 years, by the time they're 6 years, their lung function is worse. So as the age increases, so does the lung function declines. And this is very important because it's important to intervene early if we are to kind of cut off this trend. Children who have history of acute chest syndrome are more likely to have subabnormal lung function. It was found out that those who had high levels of lactate dehydrogenase had abnormal lung function, as well as those children who were from households where they use biomass for cooking, especially charcoal. All these factors are mainly environmental factors, and they also speak to what happens within the lung of a child with sickle cell disease. Again, this becomes very important when we are trying to intervene to prevent abnormal lung function or fast decline in this. Now I'll turn to the pulmonary complications. So it's important to note that these are actually very common. And I was speaking to the people who work in the sickle cell clinic in Mulago Hospital, and they actually confirmed that these are quite common. And they're not just common, they are a very major cause of ill health or morbidity and mortality in children with sickle cell disease. In some studies, they have actually mentioned that about 20% of the deaths that happen in children with sickle cell disease, it is because of these pulmonary complications. And I'll just highlight a few. So the most common one is actually infections. So children with sickle cell disease commonly have pneumonia, but I'll not discuss this. I'll focus on a few like acute chest syndrome, Pulmonary hypertension is also common. Sleep disordered breathing with nocturnal hypoxemia. They also tend to have asthma, thromboembolism, what we call the sickle cell chronic lung disease, more common in older children and adults, as well as reduced exercise capacity. I'll only discuss acute chest syndrome, sleep disordered breathing with nocturnal hypoxemia, asthma, and the reasons will become clear as we go along. But that doesn't mean that the rest of the complications are not important. And also, this list is not exhaustive. There are other complications. But what is very important is to note that these complications actually start early, in early childhood, and they're associated with a more severe course of the disease, and eventually with higher rates of mortality. So just a bit about acute chest syndrome. So studies have shown that it occurs in 10 to 20% of children with sickle cell, and it's the second most common cause of hospitalization. Actually, the leading cause of admission to an intensive care unit and premature deaths in this population. So the common presentation is chest fever, wheezing, or cough. They usually have fast breathing, they may have respiratory distress, and when you measure their oxygen saturation, they have hypoxemia. And then the radiographic definition is that there is a new abnormality, which is usually a pulmonary infiltrate. I underline the word new because it means that you should have had a prior field to compare with the new one for you to conclude that it's new. And maybe this may not be practical in many of our settings, but the definition remains that new pulmonary infiltrate, which is consistent with alveolar consolidation, but not atelectasis. It should involve at least one complete lung segment. The experts will probably discuss this further, but this chest X-ray just shows that consolidation in the left lower lobe. So what are the causes of chest syndrome in this population? Like I mentioned earlier, the most common cause of acute chest syndrome is actually infections, and especially the atypical bacteria and viruses. I know many times as we prescribe antibiotics, we may not think about atypical bacteria, but as I'll highlight later from the work that was done in the hospital, atypical bacteria are a very important cause of acute chest syndrome in this population. There was a study that was done in the USA. There is what they call the National Acute Chest Syndrome Study Group. They had quite a huge data set of 671 episodes in 538 patients. And they were able to identify an infectious cause of 54% of the cases. So it is that common cause, it's that common as a cause of acute chest syndrome. But the other pathology could be that there is intravesicular pulmonary sequestration of the sickle erythrocytes, that's the red blood cells, and they lead to lung injury and consequently the infarction. It could be embolization of the bone marrow fat. And I think this is very important because patients may come with the pain in the limbs, and they mention that usually the acute chest syndrome may 24 to 48 hours. So it's usually a good, I think, to look beyond the limb, look out for acute chest syndrome that may be developing so that you can intervene in time. So some work that has been in Uganda, there was a cross-sectional study by Ochaya and team. It was done in Mulago Sickle Cell Clinic. It was a big study involving 556 children who had sickle cell anemia and presented with fever. They did intensive investigations. They did chest X-rays, they did blood cultures, complete blood count, did vitamin induction and looked out for TB using ZN. They did DNA PCR to look out for chlamydia pneumoniae, and that is an atypical bacteria. So what did they find? They found that 22.7% of these children actually had chest syndrome, and the most common isolate from the sputum was chlamydia pneumoniae at 59.3%. So it's important to note that as we prescribe antibiotics for children with sickle cell disease who present with acute chest syndrome, we should think about the atypical bacteria as a potential cause. So I'll stop there chest syndrome, I'll not go into the depth of the management. I know the guidelines are there. I'll now move to asthma in children with sickle cell disease. Incidentally, it is a common finding with a prevalence of 17 to 28%. But we know that if a child has asthma and also has sickle cell disease, they're at higher risk of getting the vaso-occlusive painful crisis, acute chest syndrome, and premature death. So what I'm trying to focus on here is that as we get these children who have sickle cell disease, I think it's important that we also potentially look out for the possibility of asthma, because it doubles or it kind of multiplies the risk of actually death from the acute chest syndrome, from the crisis, and all that. So how does this happen that children with sickle cell disease are at higher risk of asthma, or what happens in those children? We think that the basic pathology, the basic problem when children have asthma is that they have narrowing of the airways. And because of that, and the pathology that I described earlier in sickle cell disease, they end up with a ventilation perfusion mismatch. And eventually this leads to local tissue hypoxia, a subsequent sickling of the red cells, and eventually you end up with a vaso-occlusive crisis. And secondly, it has been noted that chronic airway inflammation and airway remodeling that are common in children with asthma may also develop due to sickle cell disease. And so it may be that having sickle cell disease eventually predisposes you to developing asthma. But also we know that there are some children who may be looking like they have asthma because of the symptoms. But remember, I mentioned that sometimes they have the obstruction, which does not respond to bronchodilators, even though they may be having the wheezing and the hyperresponsiveness and the obstructive lung function. So that is for us to investigate further and find out how we can differentiate the two categories of children and treat them appropriately. So the reason why I wanted to discuss asthma and acute chest syndrome is from the clinical perspective. That's why I mentioned that, is it possible that as we practice or as we see these children, there are some things we are not focusing on and therefore contributing to unavoidable mortality. So there is a significant overlap in clinical presentation. They both present with cough, breathing difficulties, they may have wheezing, they have chest pain, and when you do the oxygen saturation, they all have hypoxemia. So how does one determine whether they have asthma or acute chest syndrome or a combination of the two? Having mentioned that when you have a combination, it actually increases your risk of death. As if that's not enough, they also have common risk factors. So the cold environment, the infections, the exercise, and other things. They're usually the same triggers for asthma as well as for acute chest syndrome. So when you take your history, you're still at a loss trying to find out, is it acute chest syndrome or asthma that is in front of me? And yet, the approach to the management is very different. In the study that was done in Uganda, it was found out that 9% of the children who had sickle cell disease had reversible air obstruction, and 18.4% had history of recurrent wheezing, which was suggesting asthma. But I was just wondering, when we look at probably the chest clinic where we see children with asthma, how many of those children actually have sickle cell disease? Is it possible that we are missing out on some of these children and therefore contributing to the mortality that we see? I'll move on to sleep disordered breathing with hypoxemia. I've brought back this diagram just to show where the hypoxemia comes from. We have the air coming in, the membrane where we have oxygen exchange into the blood vessels. But what I want to mention is that it's not uncommon that children with sickle cell disease have trouble when they are sleeping in terms of breathing. And that one is referred to as the sleep disordered breathing. And it's usually accompanied by hypoxemia. So that's why we call it sleep disordered breathing with nocturnal hypoxemia. And it has been found to be very common in children with sickle cell disease. They also we have what we call obstructive sleep apnea or ASA. And this one has been found to affect up to 40% of children with sickle cell disease. And lastly, over 1/3 of children with sickle cell disease have sustained daytime hypoxemia. So in a nutshell, we find that children with sickle cell disease are prone to hypoxemia, and we know hypoxemia sets off other events that eventually affect other different body parts, but as well as the lungs. But I am not certain how much we look out for symptoms of sleep disorders when we are assessing children with sickle cell disease. So the pathophysiology of this, we think it's a combination again of the lung parenchyma involvement, the airways, and the vasculature, which is altered. And this eventually leads to reduced gas exchange and perfusion mismatch. So how do we find out if this child might be having sleep disordered breathing? They usually present with snoring. They may have daytime sleepiness. They usually complain of morning headaches. Sometimes they have behavioral disturbances. They're either hyperactive. And when you have a child who is 6 years and older and has enuresis, probably they have sleep disordered breathing. And sometimes the parents are able to observe that there is apnea, moments when the child is completely not breathing. But if you do the sleep studies, you can actually detect this. So again, these are a few of the symptoms of sleep disordered breathing. And I think it might be important that as we assess these children, we try to look out for them, because as we have discussed, they lead to hypoxemia, which worsens the lung function of these children. So what are the consequences when children have sleep disordered breathing? There's been research which has shown that children with sickle cell disease and nocturnal hypoxemia are usually at a higher risk of intracranial arteriopathy and central nervous system events. If you have seen a child with central nervous system events and they have sickle cell disease, it's really a terrible thing to have. But we also know that those children who have low daytime oxygen saturation, they have a higher risk of getting stroke. Children who have obstructive sleep apnea, they actually have a threefold risk of having stroke. And they usually have a higher frequency of left ventricular diastolic dysfunction, as well as enuresis. So I think it's important to find out whether children have sleep disordered breathing, because we can prevent it, we can prevent these other pulmonary complications. Can I request somebody to mute? Thank you. So those are the three conditions that I thought I would discuss. Like I mentioned, it's about awareness creation. It's not about how to manage them. So now I'll turn briefly to interventions. I mentioned in summary that children with sickle cell disease usually have poor lung function. They are prone to all those complications. And the issue is, how do we then intervene? And at what point should we intervene? So I want to mention that interventions should actually start during the prenatal period. And this really cuts across whether the child is sickle cell disease or not, because we know that suboptimal lung function at birth increases the risk of sickle cell disease. But especially for the children, like those ones where we expect sickle cell disease, like Dr. Kasirye mentioned, maybe we should even intervene more aggressively during the prenatal period. And what do we focus on during the prenatal period? We should look at maternal nutrition, especially the micronutrients like vitamin D, A, E, and zinc, because these contribute greatly in lung function, growth, and development during the intrauterine period. We've done some work here in Uganda. So there is a birth cohort study that we have. We enrolled pregnant women, there's 564 women, and we looked at their nutrition. We asked them questions about the food they eat. We also measured the serum vitamin D levels. And what was very, very disturbing was that 7.6% of them actually had low serum vitamin D. The cutoff point for pregnant women is 40 nanograms per ml. So over half of them had a low serum vitamin D. And if you read through the literature, this is one of the key nutrients that are important in lung growth and development. The other environmental exposure, which is important during the prenatal period, is household air pollution. Again, we went out to measure the pollution they're exposed to in their households by measuring what we call the particulate matter 2.5. And we found out that 95.7% of them actually had levels above 100 micrograms per meter cubed. But all of them actually had their levels above the 25. 25 is the recommended or the allowable by WHO, but I bring out the above 100 because majority were way above 100 microgram mark. So in a nutshell, all the pregnant women in this cohort were exposed to high levels of air pollution, and therefore this would impact on the lung growth and development to their babies, even during the uterine period. But because the babies are going to stay in the same environment, so the exposure would continue during extrauterine life, increasing their risk of poor lung function and development of lung diseases. So this curve just demonstrates what happens to lung function and development during the prenatal period. So this is what would happen normally, that the lung growth and function at birth is normal. And then you start going up. By the time you're 22, you are reaching your peak, and then you start declining. So what happens when you have this exposure that I've talked about? By the time you are born, first of all, your lung function, growth, and development is not optimal in utero. And by the time you are born, you are not able to follow that normal curve. So your lung function is at the lower centile, and this eventually predisposes you to faster lung function decline, and you may manifest the symptoms much earlier than those who have normal growth of those who have not been exposed to those prenatal exposure. So the bottom line is that it's important to prevent lung diseases by focusing on a prenatal period as well. I'll not go through this again, but just to highlight the fact that the faster decline can happen in children with sickle cell disease just because they have those problems of repeated vaso-occlusive crises, of hypoxemia, of disordered sleep, all those events that will impact on their lungs and therefore the lung function will cause them to have faster decline and therefore higher risk of developing lung problems. So one of the interventions that has been tried, hydroxyurea, we use this for children with sickle cell disease. Maybe Dr. Kasirye will comment later on availability, and I know there was a talk about adherence and so many other things around hydroxyurea recently. But we know that it helps in reduction of the vaso-occlusive complications. It stimulates fetal hemoglobin. It impacts on the red blood cell hydration. Remember, one of the pathophysiological mechanisms is red cell depletion. So when there is red cell hydration, the deformability of the RBC is less, and therefore the rate of hemolysis is also less. It can help in lowering the number of circulating white blood cells, and therefore this helps to reducing the endothelial inflammation and vaso-occlusion, reduces the expression of those adhesion receptors on RBCs and endothelial cells, but also helps in the release of what we call nitric oxide, and this helps in reduction of platelet coagulation activation, and therefore reduces endothelial cell injury. So in a nutshell, hydroxyurea helps in all these mechanisms, and certainly when it comes to the lungs, these are very important positives for hydroxyurea because it will help in improving lung function. So there has been a study, this is not in Africa, where they had a cohort of 160 children who were more than 6 years. So they all had sickle cell disease, 25 did not receive. So at baseline for both groups, they did site count, they did as well as spirometry, and they kept monitoring adherence to hydroxyurea because it's very important. The benefits come in when you have adherence of 80%. And then they were also able to pair the decline, but basically what they did, they looked at the controls, meaning hydroxyurea and compared lung diseases. So what other interventions should we be talking about? We have screening. We could try screening. Abnormal lung function, could we consider routine spirometry? Can we do them annually? Would we be able to have research in tools that could help identify children who are at risk, like I mentioned earlier? And then lastly, I want to mention some research gaps, especially in Africa. We still have very few studies, the leading cause of morbidity and mortality. The few studies that we have are mainly observational. They are very small sample size and have happened in tertiary care hospitals. We do not have any longitudinal studies, no interventional studies. So we need to do more research in that area. And somebody, if you can hear me, somebody was saying that they can't hear me.
It is now better.
Oh. Share.
Yes, yes, Rebecca. Are you?
Okay, this is my last slide. Sorry.
Okay. Thank you, Dr. Rebecca, for taking us through the pulmonary complications in sickle cell disease, and thank you for enlightening us about the assessment. Hello, Rebecca. Are you still talking? So thank you again for enlightening us about the pulmonary function assessments, as well as the complications in sickle cell disease. This is a time for questions and comments. I can see Philemon's hand is already up. You can go ahead and pose your question. Philemon? Philemon, are you there? Can you hear us? You can unmute, or you can put down your hand if at all your issue has already been addressed. Any other comments or clarification? Yes. Philemon, you're not clear. You're not clear. You're not audible, but you can send your comments in a text. I'm already seeing that you
Yes,
need...
I do can hear you now, and I hope you can hear me.
Okay,
my question is that is it possible to have? Is it?
Yes, go ahead.
Yes, I have not been able to follow the entire meeting, and
yes, Philemon, we should be able to share these slides. Thank you. Your concern has been noted. Any other question or communication? Colleagues, if you have some network issues, you can share in the text, in the chat. We should be able to see it and respond. Thank you. Over. So as we wait for you to comment, some key points that have come up. One, sickle cell disease and the complications do not spare the lungs, and therefore it's a call upon all of us to do a whole assessment, including assessment of lung or function or pulmonary assessment. Secondly, it has served well to increase our awareness to think beyond acute chest syndrome and think along what has been shared in as far as pulmonary complications in sickle cell is concerned. And also, that has been brought up front is the issue of sleep assessment, sleep disorder assessment, asthma and sickle cell disease. Those are potential areas for research for our students, our postgraduate students. We have a wealth of patients. You can join in and explore some of those. The other issue that has come up prominently is the need to screen lung function for proper lung function. And the Makerere Lung Institute provides us with that opportunity in our setting. But of course, it starts with the history taking and the physical examination before we go further to the Lung Institute for the pulmonary function assessment. So at this time, I welcome any comments. I've seen comments that are in the line of appreciation. Thank you, Dr. Rebecca from Mozilla, from Elizabeth and others. And Akulu Vicky seeks to know, are there any other investigations or criteria one could use to assess children with SCD to ease early identification in other facilities that lack spirometry? So probably Dr. Rebecca, you could address that. What other criteria could be applied to assess for lung function? Other than spirometry, knowing that most of our facilities don't have easy access to spirometry. Thank you, over.
Thank you, Dr. Kasirye. Can you hear me? My network is really not so good.
Yes, we can hear you loud and clear. Thank you.
Okay, thank you. So the easiest test to assess lung function is actually spirometry. Sometimes we can do what we call peak expiratory flow, but it's usually not conclusive. For you to eventually conclude that this child has abnormal lung function and they have restrictive disease or they have obstruction, the mixed type, you would need spirometry. And so we think to try and see how to deal with this, we would need probably to conduct some studies so that those studies can lead to the development of what we call screening tools. And therefore, in the absence of spirometry, you would know that if previous history of acute chest syndrome, maybe this child has a 60% chance of having abnormal lung function. And therefore, my appeal would be that we get interested in this space and be able to develop tools that we can use in settings where we don't have spirometry. We don't have to.
Okay, thank you, Dr. Rebecca. So that is work in progress to come up with a friendly criteria that can be applied in the absence of access to spirometry. But probably we shall comment on that later. Any other questions for now? Would it be possible for Lung Institute to bring down these services to regional referral hospitals? Dr. Rebecca?
Thank you so much. At the Lung Institute, we are open. We actually recognize the importance of spirometry and that we need to have many more centers that can actually offer this simple service. It's a very simple and non-invasive procedure all you would need would be to have the people trained, but also get the equipment. So we're in discussions with the Ministry of Health to see if we can have this test provided so that we don't have everyone having to come to the Lung Institute to get this, this test. So it is possible. It doesn't need a lot, usually a room, simple equipment and training, but people have to put in resources to have this done. So it would be great if people within the regional referral hospital also add on their voice to demand for it. As a Lung Institute, we have the training program. We're happy to train, to mentor and support as we go along.
Thank you, Dr. Rebecca. The key message is that Makerere Lung Institute is open to training as long as we express interest in attending the training. And secondly, there is a rollout, the program on rollout, even though it has not yet happened all over the country. Probably, Dr. Rebecca, if I can restate the question about the other, how else would someone assess the lung function other than spirometry for those who are in the inaccessible areas? Thank you, over.
The is that the alternative would be to have the peak expiratory flow meter. It's a small gadget, you can even put it in your handbag, and we use it to try and assess lung function. But the downside is that it may give you an indication, but it's usually not conclusive. So it would be a good, maybe something we could use as part of screening, but to confirm what abnormality there is, you would require spirometry. So the bottom line is lung function where there is no spirometry, it becomes a challenge.
Yes, thank you very much. That has been noted, and we should drive the demand. As clinicians, we should strive to demand for the standard. Wherever we are, even though we are not yet there, let us put it into consideration, such that at point T, it will be factored in as the standard assessment. Otherwise, through history and examination, we can equally do some preliminary assessment like Dr. Rebecca earlier on mentioned, and we can be able to diagnose sleep disorders. We can be able to diagnose acute chest syndrome, amongst others. So we should take note of that as we advocate for more access to spirometry. Dr. Nantanda, a question comes back on how to differentiate between acute chest and asthma.
Yeah, like I mentioned, the reason why I discussed them together is that it's difficult to differentiate the two because of the overlapping symptoms. If you've seen a child with acute chest syndrome and another child presenting with acute exacerbation or acute attack, they're the same things. They have cough, difficulty in breathing, they are crying out of chest pain, they may be wheezing. You do the oxygen sats and they have low oxygen saturation. So it's really a difficult thing to differentiate at that point in time. But also to note that once they have an asthma exacerbation or if they have background asthma and they get acute chest syndrome, their risk of death increases. So it's such a difficult thing. So I would recommend that in such instances, if you're able to dig out more history, that would point to asthma. For example, if they have comorbidities, like if they have allergy, like chronic rhinitis, if they have family history of allergies or asthma, if they have had these recurrent nocturnal symptoms. So you can attempt to dig deeper so that you're able to probably think about the possibility of asthma and therefore be able to manage both. Now, the other thing would be that when that child stabilizes, then you would need to perform spirometry and do reversibility testing, meaning that you do spirometry before you give the bronchodilator like salbutamol, and then you also measure lung function after giving salbutamol, and therefore it will show you if this child has an obstruction, if it's reversible, that would usually point to asthma. So again, if you're able to catch these children early before they get into that acute state, it would help so that by the time they come in with those symptoms, we are probably already thinking about a possibility of both. Cost of spirometer, right now it's 100,000. The test, it's high because of the consumables, which we need to buy from abroad. But I believe if the demand is high and they're in many places, we can gain from having mass procurement and within the government system, and that would make the test much cheaper for the patients.
Thank you very much, Dr. Nantanda.
Oh, yeah.
You can go on.
I was
the question
through the
from
chat,
Irene.
yes. So the question is, once a diagnosis of restrictive or obstructive lung disease is made, what is the management then for these children? What prevention strategies? So when I say, or when we conclude that this child has restrictive or obstruction, that is not a diagnosis. It is just a result of that test. For example, if you do a CBC and you find out that this child has HB of maybe 6, you'll comment that this HB is low, but you need the clinical picture to find out what is causing the low HB in this child. The same thing applies. So when spirometry says there is restriction or obstruction, that is what the lung function is like, but you need to dig again what is causing it. But in simple terms, restriction means that the lungs are not expanding appropriately, and this is usually because there is fibrosis or there is atelectasis or whatever it is that is preventing the lungs from expanding properly. While obstruction usually points to the narrowing of the airways. So you have to go back as a clinician in this child who is in front of you. What are the possible causes of these lung function defects? And that will eventually inform the management, because there are many causes of restriction, there are many causes of obstruction in children and in adults. What prevention strategies are in place to prevent deterioration? Again, it depends on what the disease is like, but just for this particular discussion, we've already shown that if you find a child has suboptimal lung function, whether they have restrictive disease or obstructive defect, and you start hydroxyurea, you have a chance of preventing lung function deterioration. If a child, for example, has asthma and you've diagnosed that, once you start them on asthma medication, then you're going to have their lung function get better. If you added the hydroxyurea in that space, if they have sickle cell disease, it even becomes better. So again, the prevention mechanisms, depending on what you think is the underlying pathophysiology, but also the disease process or the diagnosis that you eventually have. What interventions can be done on obstructive? I think it's the same thing that I would mention. It depends on what is causing the obstruction. It's either therapeutic, but other preventive mechanisms is prevention of those the environmental exposures that I mentioned, cause in the lung function. So if you're able to quick or faster decline in the lung function. Okay, another question. Hydroxyurea early before complication setting is the way to go. I entirely agree with you. I read a paper where they did research. I think they started giving hydroxyurea at 9 months, and certainly these children had better lung function when they compared to their counterparts who had not started hydroxyurea early. And since we already have evidence that these pulmonary complications start early in life, so the earlier we start the preventive mechanisms that are in front of us, the better. But of course, there are issues of cost and other things which we need to factor in. But I agree with you, we need to have advocacy. So at what cutoff age for children do you consider FVC of 3 seconds? Usually we can go up to 12 years. Adolescents sometimes are similar to adults, but generally speaking, 3 seconds, they should have the full FVC. But maybe to just share that when it comes to lung function, there are many other things we need to consider and interpret in context. So we may not be able to discuss all the lung function indices in this discussion. When you start hydroxyurea, I think Dr. Kasirye study where they started it at less than 1 year and they had better outcomes. Okay, I think that's what I can see in the chat. Over to you, Chair. Thank you.
Thank you very much, Dr. Rebecca, and a big thanks to all of you who have managed to log in for this important subject of discussion. So, like I said, like someone has intimated, early identification of our patients, as well as early enrollment into care and initiation on preventative measures, including hydroxyurea from 9 months of age, is the way to go. Of course, the environmental modification to prevent lung injury has been mentioned. And above all, the prevention. Let us strive to see that we get no more patients with sickle cell, born with sickle cell anemia. And it starts with you and it starts with me. I think at this moment, we come to the end of this webinar, which has been well attended, and much appreciation to all of you and Makerere Lung Institute, partnering with the Mulago Makerere Hospital. Thank you, and over.
Thank you, everyone. Have a good day.
Thank you, Chair Dr. Kasirye and Dr. Rebecca. Greetings from Arua.
Thank you, Gilbert, and greetings to all of you. Bye-bye.
Thank you from
Thank you.
Bali.
Adesso, bye.
Thank you.
Bye bye.